Bismillahirrahmanirrahim. Assalamualaikum and very good morning to everyone. Welcome to CPC, Fakulti of Medicine, Universiti Kebangsaan Malaysia. From Department of Pediatrics today, we are going to discuss an interesting case titled A Child with Chronic Cough and Chest Pain. It is my pleasure to introduce our presenters and invited panelists today. Dr. Chong Si Jia, a young pediatrician from Department of Pediatrics at HPKK UKM. Dr. Doris, a pediatric hemato-oncologist, Department of Pediatrics, HPKK UKM. Associate Professor Dr. Faizah Zaki, a consultant pediatric radiologist from HPKK UKM. Associate Professor Dr. Suria Hayati, a consultant pathologist from HCTM. And last but not least, Dr. Marfu'ah a consultant clinical oncologist from HCTM. Thank you for being with us today. Before we start, some housekeeping for the audience. If you have any questions, please use the chat box to write and post the question. The Q&A session will be at the end. However, if time permits, we may allow some questions in between the speakers. And for the medical students, the quiz will be at the end of the session. So please stay until the end of this CPC. So without further ado, I would like to invite the first presenter, Dr. Chong Si Jia, to start her case presentation. Si Jia, you may start.
Right. Sorry, give me a minute. Okay, sorry for the delay. I'm Si Jia for Department of Pediatrics. I'll start my CPC presentation with a case presentation. So this is a 12-year-old boy presented with intermittent non-productive cough for 1 month, right-sided chest pain upon coughing for 2 weeks, history of fever for 2 days during first week of illness, and he was noted shoulder tilted towards the right side. He had received a course for antibiotic from general practitioner. He did not complain of palpitation, no shortness of breath, no loss of weight, and no loss of appetite. He did not have significant past medical or surgical history. He was born term via elective lower segment cesarean section with 2 previous scars, birth weight of 3 kg. His immunization was completed for age. He had isolated speech delay at 2.5 years old and later diagnosed with mild autism spectrum disorder at 3.5 years old. He was ADL independent, studying in special class at private Chinese school. He was able to interact with others using simple sentences. He was the youngest out of 3 siblings. His parents and 2 elder siblings were healthy. Upon examination, he was alert with good eye contact. He was afebrile with temperature of 37 degrees. He was not tachypneic and not tachycardic, respiratory of 22 breaths per minute, and heart rate of 95 beats per minute. His blood pressure was normal tensive, BP of 100/05 over 60 millimeter per mercury. SpO2 was 99% under room air. He was a thriving child with weight at 50th centile and height at 10th centile. His throat was not injected. He did not have digital clubbing, no limb adenopathy. BCG scar was seen on left arm. Shoulder was noted tilted towards the right side with scoliosis. Tenderness at right lower rib. Trachea was not deviated. Upon lung examination, was noted chest expansion reduced over right lower zone. Breath sound was reduced right mid to lower zone with stony dullness of percussion. There was no crepitation or rhonchi. A PET speed was at left fifth intercostal space, mid-clavicular line. Abdomen was soft, not distended, and no hepatosplenomegaly. Initial blood investigation showed a normal full blood count, with white cell count of 9.2, HP of 12.4, platelet of 321. He had a normal renal profile and liver function test. He had a slightly raised CRP of 2.24 milligram per deciliter with cutoff point of 0.5 milligram per deciliter as a raised CRP. In summary, he is a 12-year-old boy with chronic non-productive cough for 1 month and right-sided periodic chest pain for 2 weeks. Upon examination, he was thriving, afebrile, not in respiratory distress, with moderate right pleural effusion with no mediastinal shift. He also had scoliosis. The new finding of scoliosis possibly could be due to the complication of pleural effusion, as patient tends to lean towards the side of pleural effusion to reduce their periodic chest pain due to distension of the pleura. So I'll move on to my differential diagnosis. My first thing that I want to consider would be infection cause of pleural effusion, as infection accounts for most of the causes of pleural effusion in children. My first differential diagnosis will be pulmonary tuberculosis, as tuberculosis is endemic in Malaysia, given the history of non-productive cough for 1 month with right pleural effusion. However, points against would be he did not complain of any constitutional symptoms. He did not have loss of appetite, no loss of weight. He was a thriving child and vaccinated with BCG vaccine, and there was no lymphadenopathy. Further history I would like to ask is that any hemolysis, any night sweats, and any TB contact. I would like to do further investigation, including a full TB workup. ESR of more than 100 millimeter per hour is associated with active tuberculosis infection. Mental test in duration of more than 10 milliliter would be positive for TB. I would like to order for sputum AFB, TB culture, and also TB PCR as well. I would like to do a chest X-ray in which a primary TB will typically show consolidation more over the lower lobe and also hilar and mediastinal lymphadenopathy, while in reactivation of TB, consolidation would more commonly involve the upper lobe with cavitation seen. I would like to do an ultrasound thorax also to look at the pleural effusion. So ultrasound thorax is a better modality to determine the quality and quantity of pleural effusion, detect loculation, and determine the best site for thoracocentesis. I would like to proceed with pleural fluid analysis. In pulmonary tuberculosis, the pleural fluid will typically be clear and straw color, lymphocytic predominance with exudative picture. I will also include a pleural fluid TB culture and TB PCR as well, and adenosine deaminase, which is an enzyme released by T-cell lymphocyte. TB is actually a cell-mediated immunity, which includes activation and proliferations of T-cell lymphocytes. Hence, adenosine deaminase will be raised. I also do interferon gamma, which is a cytokine released by T-cell lymphocytes. I'll proceed with pleural biopsy as well, in which typically will show a granulomatous inflammation with accumulation of lymphocytes and some mononuclear cells on the pleural tissue. My second differential will be mycoplasma pneumonia with parapneumonic infusion, as given the history of unresolving non-productive cough despite a course of antibiotic. Pleural effusion can be associated up to 20% of patients infected with mycoplasma pneumonia, and they can have a normal white cell count as well. However, points against would be the patient only had fever for 2 days, lungs, there was no crepitation as well. Further history I would like to ask is that any extrapulmonary symptoms, because extrapulmonary symptoms can be associated up to 25% of mycoplasma infected patients. For example, any rash, any anorexia or nausea, any headache, and any arthralgia. Further investigation would include a mycoplasma serology, in which antibody titer of more than 1 in 160 will be positive for mycoplasma infection. I will do a chest X-ray as well, in which it will show reticular nodular obesities or bronchial cuffing. Ultrasound thorax to assess the pleural effusion. I'll do a pleural fluid analysis in which it will show a serous colored fluids with alkaline pH and lymphocytic predominance with exudative features. I will also include a pleural fluid culture as well. Next, I will consider malignancy as cause of pleural effusion in my patient, given the history of chronic cough for 1 month associated with pleural effusion. Malignancy accounts up to 10 to 15% of cause of pleural effusion in children, and lymphoma is the most common cause of malignant pleural effusion in children. However, points against is that this patient did not complain of constitutional symptoms. Upon examination, there was no lymph adenopathy. However, non-Hodgkin lymphoma can present with extranodal disease. His full blood count is normal. However, it can be normal if there is no marrow involvement. Further history, I would like to ask any symptoms of suprarenal cava obstruction, for example, face or neck swelling and autonia. And I will ask any family history of malignancy as well. I would like to examine for any signs of SVC obstruction, any face and neck edema, and distended neck vein. Further investigation will include a full blood picture to look for any leukoerythroblastosis changes which suggestive of bone marrow involvement. LDH and uric acid would reflect a tumor burden. Chest X-ray will show bulky mediastinal mass and myhila and mediastinal lymph adenopathy, while CT thorax which helps to assess the mediastinal mass, any chest wall invasion, and any mass effect. Pleural fluid analysis will show a pleural fluid colored of a hemoserous colored with exudative picture. I will also include a pleural fluid cytology, will typically show abnormal lymphocyte cells with increased nuclear to cytoplasmic ratio. And then I will also do the pleural biopsy as well. Diagnostic investigation would include CT-guided biopsy of the mediastinal mass. I will do a bone marrow aspiration and trophine biopsy to rule out any bone marrow involvement. The next differential diagnosis will be a chest wall tumor, for example, chest wall rhabdomyosarcoma or Ewing sarcoma, as patient did have a local tenderness over the right lower rib. Further history, I would like to ask any chest wall swelling, any aggravating factor of the chest pain due to exercise, or was it worse at nighttime? However, the chest pain description given was chest pain upon coughing instead of chest pain persistent throughout the day and worse at night. I would like to examine for any chest wall mass during my examination. Further investigation will include a LDH, which acts as a prognostic factor. Chest X-ray, I will also do a chest X-ray, ultrasound thorax, CT thorax, and also bone scan as well. In the case of rhabdomyosarcoma, chest X-ray will show a soft tissue mass, and CT thorax to help us to assess the mass better, any mass effect, and any chest wall invasion. While in the case of Ewing sarcoma, chest X-ray will show primitive lesion or moth-eaten lesion, and CT thorax will determine the degree of cortical disruption. I will also do a pleural fluid analysis, including pleural fluid cytology, in which rhabdomyosarcoma may show characteristic of cross striation or myofibril, which suggestive of skeletal muscle in origin. While in Ewing sarcoma, you will see a small blue round cells in cluster. I will do a biopsy of bone or mass if present. My last but not least of differential diagnosis is lung metastasis, for example, from Wilms tumor or osteosarcoma. Lung metastasis is actually much more common than primary lung malignancy, with a ratio of 5 lung metastasis to 1 primary lung malignancy. So the most common sites of metastasis for Wilms tumor and osteosarcoma is actually the lung. But however, points against is that patient did not have any constitutional symptoms. For further history, for Wilms tumor, I would like to ask any abdominal pain, any hematuria, and examine for any palpable abdominal mass. For osteosarcoma, I would like to ask any bone pain and swelling and examine for any bone swelling. Further investigation will include a chest X-ray, which typically showed cannonball metastasis features, which is described as well-circumscribed, rounded nodules scattered throughout the lungs, and CT thorax will assess the pulmonary nodules even better. For Wilms tumor, I would like to order for urine analysis to look for any hematuria, renal ultrasound to assess the renal mass, and MRI abdomen for staging purpose. For osteosarcoma, X-ray of the limb will typically show Cosman triangle with sunburst appearance, and I will do an MRI of the involved limb for local staging purpose. That's all from me.
Okay. Thanks, Si Jia. Dr. Doris and Prof. Faizah will give some of the information that you have requested, as well as the initial imaging, which is chest X-ray and ultrasound. Okay, so I invite Dr. Doris and Prof. Faizah to give the initial investigation for this patient.
Thank you, Prof. Hasniah and Dr. Chong. So for this section, both Prof. Faizah and me will be conducting this part. So with regards to the further history that Dr. Chong has inquired, so the patient has no hemoptysis, no night sweats. There's no history of contact with a TB patient or anyone with chronic cough. There's no extrapulmonary symptoms suggestive of mycoplasma pneumonia infection, such as rash, headache, or arthralgia, and the family history of malignancy is negative. Further examination, there's no signs to suggest a SVC obstruction. There's no mass palpable per abdomen, and there's no bone swelling. So we did some baseline investigations, apart from the full blood count, RP, and LFT that was given earlier. So these are some of the tests that we have performed. The MEN2 test is 10 millimeter. ESR is 93 millimeter per hour. Serum LDH is 354 unit per liter. Uric acid is 175. Mycoplasma pneumonia agglutination test was negative, and gastric lavage for acid fast bacilli ×3 was also negative. So we did some imaging. So over to you, Prof. Faizah.
Okay, Assalamualaikum and good morning. So thank you very much, Chong, for the request. You requested for chest X-ray. Would you like to comment a bit on the chest radiograph that was done upon the admission?
All right.
What do you think about the radiograph?
Yeah, this is a chest X-ray of PA view. Chest X-ray showed a right moderate pleural effusion as evidence of blunting of the right costal phrenic angle, and also obliteration of the right diaphragm and obliteration of the right cardiac border. However, the trachea is still central with no mediastinal shift.
So what will be your impression at the moment? Based on the differential diagnosis that you have earlier?
So my first provisional diagnosis, tuberculosis, as evidence with a positive MEN2 test of 10 millimeter, and also but I would like to also confirm with a TB PCR as well, and I will have ruled out mycoplasma infection already because mycoplasma serology was negative, and yeah, and malignancy cause still cannot be ruled out at this moment.
All right, Doris, can I have the next slide, please? All right, so you correctly mentioned that there's a pleural effusion, and then don't forget there's also a consolidation whereby you see some opacity at the region of the lung parenchyma, which is not the effusion itself, but you can see some fluffy area around that region, and it actually obliterates the right heart border. So that means you did mention that the right hemidiaphragm is obliterated, so that means the problem, I mean, the pathology is happening in the right lower lobe, but it also affects the right middle lobe because it has obliterates the right heart border. Okay, so can we have the next slide? So the patient has an ultrasound that was done because ultrasound is superb in terms of assessing the pleural effusion. So what we have here is that this hypo or anechoic area is the area of the pleural effusion, and then we have this consolidation which is adjacent to that. Have a look closely at the pleural effusion because we do not see any septation at the moment. And then what we only see is just the a black area that what we normally call as anechoic on ultrasound. Okay, so anechoic on ultrasound actually indicates fluid. And whenever we see some more areas of septation, that means there's already fibrin and inflammation happening, which I will tell you later. So can we have the next slide? At this juncture, the differential diagnosis is actually based on the common things first. Okay, so we go for a common thing for which actually cause a parapneumonia effusion, which is infection. At the same time, we see consolidation, which supports that. And thus our first differential would be bronchopneumonia. It can be bacterial, or as you said, it can actually still be a tuberculosis, which has involved the parenchyma and pleura. The less common would be malignancy, which is 10 to 15% of cases. And one of the differential would be lymphoma. We do see this a lot. Patient come with lymphoma, abdominal lymphoma, but with pleural effusion, and also a pleural tumor, for example, a pleuropulmonary blastoma. Okay, so I think I give back to Doris because the imaging part at the moment is done.
Okay. Thanks, Prof. Faizah. So, Dr. Chong, what will you do next for this patient after you have seen actually some of the information and also the initial X-ray and also the ultrasound of the chest?
I will do a diagnostic pleural tap for example, I will send for a pleural fluid cell count and look at the pleural fluid color. I will send a pleural fluid LDH, pleural fluid protein, and pleural fluid glucose as well to determine whether is it a transudative cough or exudative cause of the pleural effusion.
Okay, Dr. Doris, you may continue with the next slides.
Okay, so we actually perform a pleural tap and we drain out 100 ml of hemoserous fluids, and these are the analysis of the pleural fluid. So would you like to have a look at the pleural fluid results, Dr. Chong, and tell us what you think?
All right, this pleural fluid shows an exudative features as evidenced by the pleural fluid to serum LDH ratio is 11, which more than 0.6 is equivalent to exudative pleural effusion, and pleural fluid to serum protein ratio is 0.68, which is more than 0.5, which is also suggestive of exudative picture as well. In terms of the pleural fluid color, it is a blood stain, probably in the case of malignancy, the pleural fluid will be hemorrhagic in feature. But however, although in tuberculosis mostly is clear or straw colored, but it can be sanguineous as well. And there's no bacteria seen with negative culture, so less likely is a bacterial cause of pleural effusion. Meanwhile, the pleural fluid acid fast bacilli is negative. However, AFB in pleural fluid is a bit more difficult to obtain because the number of AFB is minimal, can be minimal in pleural fluid. I would like to confirm further with TB culture and TB PCR. And cytology shows no evidence of malignant cells.
So can you narrow down your differential diagnosis at this point?
So my first differential was still pulmonary tuberculosis given a positive mental test and exudative picture. However, I don't have a cell count I don't have a cell count result for this patient. And my second, I've ruled out mycoplasma infection, but however I ruled out mycoplasma and bacterial infection, but I have not ruled out malignancy cause.
Okay, so the next line of investigation, what will you do?
Next, I will do I will wait for the TB PCR result, and further because the diagnosis is still not clear at this moment. Probably I will do a video assisted thoracoscopy to find out what's the cause of the pleural effusion. I will do a pleural biopsy as well.
All right, Dr. Doris will tell you the progress of the patient.
Okay, so I will just do a quick summary of the case. So basically, this is a 12-year-old boy with chronic cough and pleuritic chest pain. There's no persistent fever and there's no constitutional symptoms, no PTP contact. Clinically, the child is not tachypnic, and the child has a right exudative pleural effusion with markedly elevated ESR. Mental and gastric lavage AFP at the time is negative. So we do have some dilemma when we manage this patient who has a chronic cough and chest pain, and the investigations are not conclusive at the moment. So whether, as what Dr. Chong has mentioned, whether this is TB or whether this is malignancy. Now, the TB culture and PCR is still pending. So while waiting for that, we decided to proceed with a CT thorax actually. So the CT thorax will be discussed in length by Prof. Faizah in the subsequent section, but it actually shows the presence of a right necrotizing pneumonia with empyema thoracis. So the patient on admission was started on IV azithromycin, but following the CT thorax findings, we actually decided to start the patient on IV cefuroxime, high dose, and the patient received a total of 7 days of IV cefuroxime. And we also decided to refer to pediatric surgical team for VETs, primarily to debride and drain the empyema, but also to look for possible cause of the pleural effusion, whether this could still be a malignancy, because we have not totally ruled that out yet. But although the VETs was planned, but the PCR from the pleural fluid came back positive for Mycobacterium tuberculosis at that time. So the VETs was postponed and the patient was started on anti-TB treatment. 2 weeks after commencement of the anti-TB treatment, the patient's right-sided chest pain persisted, and he has new complaint now. He has epigastric pain, possible a referred pain, and also reduced effort tolerance. So we decided to repeat the X-ray together with the ultrasound thorax, which showed a worsening of right pleural effusion, and we decided to proceed with VETs. During VETs, 500 ml of hemoserous fluid was drained. The right lower lobe pleura was thickened, vascularized, and densely adhered to the lung, and this part of the pleura was biopsied.
Okay, so the pleural biopsy was sent for HPE. Prof. Suria will present the HPE results. Yeah.
Thank you, Prof. Hasniah. So I will discuss on the histopathological examination or the pleural biopsy. Yeah. The pleural biopsy, we received in the lab a fragment of tissue measuring about 2.5 cm in maximum dimension, and we have entirely submitted the fragments for assessment. Okay, so microscopically, what we see under low power, we can see strips of fibrocollagenous tissue here. And within the fibrocollagenous tissue, you can see glandular formation, small, few foci of neoplastic glands formation, okay, as shown by the arrow. And with under low power, we did not see any squamous differentiation, and there is no normal lung tissue seen. Okay, on higher power view, you can clearly see the glandular formation, okay, formed by the neoplastic cells. And we can also see areas of tumor necrosis on the right-hand side. Okay, on higher power view, you can appreciate that the neoplastic cells show enlarged vesicular nuclei, and it also has prominent nucleolus. Okay, and within the lumen you can see tumor necrosis, and this is also a tumor necrosis. Okay, so from the morphology of the tumor, we can conclude that this tumor form a complex glandular structure with lumen at the center. So this is an adenocarcinoma. But the dilemma is whether this adenocarcinoma comes from lung, which is primary lung carcinoma, or is it metastasis from other sites? Okay, the cytomorphology of both can be similar. So how to definitely diagnose the origin of the tumor? Okay, in histopathology, we can do immunohistochemistry stains or studies to detect antigen that is present on the tissue sample. Okay, in this case, the cells of interest is the tumor cells. Okay, so we will apply a panel of antibody to the tissue, and if the tissue is present on the cells, it will bind and give out a colored product. Yeah, I'll show you an example of positive study. Okay, the left picture is showing if there is a positive, there is an antigen presence on the cell which give a brown or red stain, and if the antigen is not present, the tissue will remain blue like this. Okay, on the right, the picture on the right. Okay, so a pathologist is able to determine the origin of the tumor cell based on the interpretation of panels of antibody used to stain the tumor. Yeah? So this is a table showing the example of immunohistochemistry study antibody that we can apply to detect a differentiation of cells. Okay, for this case, the tumor is positive for cytokeratin 7. Cytokeratin is an epithelial marker. Okay, example of cytokeratin 7 positive tumor include lung primary, pancreatobiliary, kidney, breast, urothelial, salivary, and gynae or gastric. As you can see, there's a wide range of tumor that can be positive to CK7. Okay, further IHC studies, so we do thyroid transcription factor 1 or TTF1. Okay, and it came back as positive. TTF1 positive is seen in thyroid tumor as well as lung tumor. Okay, and NAPSIM-A is another marker that it will be positive in lung adenocarcinoma and clear cell carcinoma of gynae tract. So as a summary, this tumor is a gland-forming tumor, malignant tumor, with positivity to CK7, TTF1, and NAPSIM. With this, we can conclude that this tissue, the tumor, is an adenocarcinoma, which is consistent with lung primary. So there is no evidence of inflammation in the biopsy.
Okay, thanks, Prof. Suria. So yeah, so the exact diagnosis for this patient is actually primary adeno-CA, which is
Yes,
actually
correct.
extremely rare in children. We didn't actually expect this. Okay. So I invite again Dr. Doris to continue with the case to look into the progress of this patient, as well as to do some of the literature review on the approach of the patient.
Thank you, Prof. Hasniah. So just a quick summary on the progress of the patient. So the final diagnosis is a primary lung adenocarcinoma. So because this diagnosis is very rare, so a consult was done with an adult oncologist from HCTM. We actually sent a genetic test for EGFR gene mutation, which was negative. Patient was started on chemotherapy based on the adult protocol, which consists of 3-weekly gemcitabine and cisplatin. Anti-TB treatment was continued, but it was ceased later when the TB culture came back as negative. He remained stable for 6 months and he received a total of 6 courses of chemotherapy, but subsequently he deteriorated, was put on palliative care, supported by the hospice. He succumbed 11 months from the diagnosis. So my part will be very, very basic, more for the medical students and also for the junior doctors. I'm going to talk about the approach to a child with pleural effusion and how to differentiate malignant pleural effusion from other causes of effusion. So the pleural space is lined by 2 membranous pleural sac. The outer layer is called the parietal pleura. The inner layer is the visceral pleura. Between this pleura, there is a fluid which consists of about 5 to 15 mils of fluid, which prevents the friction when the pleural sac moves. Pleural fluid is actually produced by the parietal pleura and reabsorbed by the parietal lymphatic system. And any disruption in this mechanism of production and absorption is going to cause pleural effusion. So as mentioned earlier by Dr. Chong, the most common cause of pleural effusion is, of course, the infection, followed by malignancy. We do have other causes of pleural effusion, namely the renal and the heart and the liver causes, but it is not going to be covered in this section. So for infection, the most common causes of pleural effusion is by streptococcal pneumonia, Staph aureus, or Mycobacterium tuberculosis. Mycoplasma pneumonia can also lead to development of pleural effusion, but it is not very common. So history-wise, the patient usually will present with cough or dyspnea. And if pneumonia is the underlying cause of the pleural effusion, patient will have fever. Of course, if malignancy is one of the cause, the patient can also have fever. Patients may also have constitutional symptoms, night sweats and hemoptysis if TB is one of the cause of the pleural effusion. We also need to ask whether the patient has any close contact with TB patients and whether the patient is immunocompromised. It is important for us to also know whether the patient is vaccinated against tuberculosis and whether the patient has received a pneumococcal vaccination. Clinical examination-wise, we need to look for signs of respiratory distress, including oxygen saturation, recessions. We also look for BCG scars and presence of lymphadenopathy and signs of pleural effusion. In a massive unilateral effusion, the patient may also have mediastinal shift and tracheal deviation. Early phase of pleural effusion, we can find pleural rub, but this will disappear once the effusion increases. And of course, we need to look for signs specific to the underlying cause of the pleural effusion. So diagnostic tools, apart from the full blood count, full blood picture, effective markers such as CRP, PCT, or blood culture, TB workup, etc. We also need to do imaging, which includes radiology, chest X-ray, ultrasound thorax, and CT thorax if it is indicated. And of course, it would be good if we can get the pleural fluid for further analysis. Pleural biopsy is only performed if it is indicated. So for the benefits of the medical students, we will do a quick revision on the LIGHTS criteria. So we need to differentiate between exudative and transudative effusion, which will be determined by looking at the protein and the LDH ratio, the pleural and the serum ratio for the protein and the LDH. So for exudative effusion, the pleural to serum protein ratio will be more than 0.5, and the pleural to serum LDH will be more than 0.6. Of course, when you look at the pleural fluid, you will also look at the cell counts and also send for cytology analysis. Some of the diagnoses may have overlapping findings. For example, if you have a high LDH, of course, we will think of malignant pleural effusion, but any exudative causes will have high LDH. For example, infection or lupus. Eosinophil predominant is seen in malignant pleural effusion, but it can also be seen in idiopathic causes of pleural effusion or in parapneumonic effusion. So a quick algorithm on how we approach a child with pleural effusion. Of course, what we keep emphasizing is you must get a proper history, do a proper examination, and then the X-ray will guide you. And if the underlying cause is more of a cardiac, liver, or renal of origin, then we treat the underlying cause. But if it is not, then we will proceed with ultrasound-guided thoracocentesis if the fluid is enough for us to tap, and then we will analyze the pleural fluid. So based on the LIGHTS criteria, we will decide whether this is a transudate or exudate. And then you will decide whether you need to do a CT thorax if the diagnosis is still not clinched at this point of time. and maybe you will need to proceed with VETS and also pleural biopsy. So for malignant pleural effusion, if the malignancy has infiltrated into the pleura, either primary or metastatic, it can actually invade the lymphatic drainage of the pleural space, and this will lead to reduced drainage and accumulation of the pleural fluid, leading to exudative pleural effusion. Of course, the cancer itself can also induce inflammatory response, leading to migration and release of the cytokines at the affected sites, such as T helper 17 cells, and this will increase the permeability of the pleural capillaries and increase the fluid leakage across the capillary and leads to effusion. Among the common causes of malignant pleural effusion, as mentioned earlier, lymphoma is the most common cause. Other causes will include mediastinal germ cell tumor and T acute lymphoblastic leukemia or lymphoma. These three causes will lead to development of anterior mediastinal mass and pleural effusion. Neuroblastoma, especially the thoracic neuroblastoma, can lead to development of posterior mediastinal mass and also pleural effusion. So when to suspect malignant pleural effusion, what we can say is it is not easy because the history-wise, it will overlap with other causes and usually it is non-specific. Presence of fever does not exclude it, but in the absence of fever, especially in our case, then we need to have a very high index of suspicion and think of possible malignancy as the underlying cause. Bear in mind that 6% of the patient may be asymptomatic and family history most of the time will be negative. Of course, some patients will have most of the patients with malignant pleural effusion will have unilateral pleural effusion, but 10% of the patient may present with bilateral pleural effusion. If there is presence of mediastinal mass, then the patient may have signs of SVC obstruction. So these are the things that we need to look for when we examine the patient. And of course, we look for any presence of significant lymphadenopathy and also hepatosplenomegaly. So the radiological features will be covered by Prof. Faizah, so I will not be touching on this. So to obtain the diagnostic samples in malignant pleural effusion, so the proper technique is very, very important. But of course, there will be overlapping in the clinic, in the findings, laboratory findings also. So most of the patients will have exudative pleural effusion, but 10% of the patients may be transudative in nature. 50% of the cases may be lymphocyte predominant, but of course, this may also overlap with other diagnoses, for example, tuberculous effusion. And cytology is only positive in 60% of the cases. So a negative CSF, negative pleural cytology does not exclude malignancy as a cause. So of course, the best is if we can do a pleural biopsy, CT or ultrasound guided, if we can see where is the pleural thickening, gives rise to a sensitivity of more than 70%. But if we perform the pleural biopsy under VETS, then the sensitivity is more than 90%. So the take-home message here is malignant pleural effusion can be difficult to distinguish from the other causes of pleural effusion, and we require a high index of suspicion. And a negative pleural fluid cytology does not exclude malignancy, and the pleural biopsy increases the yield of obtaining a positive result in malignant pleural effusion if it is done under CT guided or during VETS. Thank you.
Thanks, Dr. Doris. So I think there's some question from Prof. Chia. Yeah, the fluid cytology should, for me, histocyte, alert the team on the underlying tumor present. Yes, I think in this case we suspected the malignancy from the beginning, right, Doris?
Yes, Prof.
Yeah. And then the rate of the false positive in TB PCR. Would you like to answer that, Doris?
Yeah, so indeed, in this case, I think the TB PCR actually it's quite misleading when it is positive, when the culture came back later as negative actually. So when we did a bit of search on the literature review, false positive is not very common, probably maybe less than 10%, but there are some reported cases, and they do say that probably this is because of contaminant from the DNA rather than problem with the sampling and all that. It's more to the laboratory contamination.
Yeah. And also the initial CT scan also showed it's a necrotizing pneumonia that I mean we are still on the line of the infection. Okay, Prof. Faizah will continue the presentation showing all the radiological investigation that was done for this patient from the beginning until and also some of the progress when he went through all the treatment. Prof. Faizah.
Assalamualaikum, and thank you very much, Prof. Hasniah. So I'll be presenting on the radiological aspect. I think we've covered on the chest radiograph and the ultrasound, but there will be some key points that I will discuss a bit later. So this child actually had a contrast enhanced CT thorax on the 20th of November. That was actually about more than a week after the first presentation. So what we can actually see that there is areas of consolidation, and also there is a pleural effusion that has an enhancement of the pleura here. And this is the corresponding area of the in a lung setting. So this is a soft tissue setting, and this is a lung setting, which basically lung setting will delineate more on the lung parenchyma. As in this case, we do see the consolidation that we saw on the X-ray, and as well as on the contralateral chest, we do not see any evidence of consolidation or nodules. So a bit of higher area of on the CT level. So you can see more of the pleural effusion and the consolidation. At this point, we do see some area of non-enhancing. So normally a consolidation will actually enhance because they still have vessel that supplies the collapsed or consolidated lung parenchyma. But whenever we do not see any enhancement, that means there's a devoid of enhancement. So we do have to suspect, is there any necrotized cells that actually occur at that region. But this is just the coronal section of it. Again, the pleural effusion is quite moderate. And then you do see there's enhancing pleura, which indicates that there is a area of inflammation occur in the pleural space. But at the same time, the consolidation itself does show some areas of non-enhancement, which indicates a necrotized area. So our observation at that point is a necrotizing pneumonia with empyema because of the, we call it as split pleural sign on that enhancing pleura. But this can actually be caused by bacterial or tuberculosis. So we can't really differentiate between the two. And this is the second chest radiograph that was done when the child had a worsening of symptom, and you can see there is more pleural effusion that occurs. We almost lost the previously seen consolidation, and the ultrasound beautifully showed that there is a huge area of a fluid, an echoic fluid within the pleural space, indicating a pleural effusion. But again, we do not see any evidence of fibrin, which normally will be seen in bacterial infection a bit more earlier. So that's why, the provisional of whether this is TB or is something else, which, a malignant effusion has been raised. So just to give a summary of the chest radiograph, so this was the first presentation, and then we did ultrasound, and we did tapping, ultrasound guided tapping. At that time, the fluid profile is exudative. So CT scan at that time was done and then showed a necrotizing pneumonia with empyema. And the patient had anti-TB done, started on anti-TB, because of the TB PCR positive. And then the child was discharged and had worsening of symptom. And thus, the chest radiograph actually showed a worsening of pleural effusion. And this is the corresponding ultrasound that I showed earlier. And what we see, so the VET was actually done, I think a week after that. And this is a immediate post-vet chest radiograph. It show reduction in the pleural effusion, but the lung is still not yet expanded at that time. And at this point, the HPE was adenocarcinoma. Even CT abdomen and pelvis was done. There's no other primary lesion to exclude, metastasis from other area. And then on the 10th of January, the chemotherapy was started. Chest radiograph was not done in between the chemotherapy, but CT scan was done. I'll show you later on the subsequent slide. And this is the chest radiograph at the time when the child had worsening shortness of breath and at the point when the palliative care was imposed. So a summary of the CT scan. So we start at the time when the tapping was done, day 3 of admission on the first presentation. And then we had the CT scan, which I showed earlier, the empyema as well as the necrotizing pneumonia. And we at that time the TB was started and VATS was done, and this the subsequent CT scan actually showed reduction in the pleural effusion with quite a persistent area of the necrotizing lesion. So at this point is the even before that we've already suspected that can this be something else, because it does not follow the routine of what a bacterial or TB pneumonia would be. Normally it would show more fibrins as the time goes by, but in this case the pleural effusion is so anechoic and that the necrotized area remains the same. So after the VAT, then the HPE was comments and of adenocarcinoma, chemotherapy was started. So the child actually quite well after the chemotherapy. You can actually see that the pleural effusion is better, and then the hypodense lesion is getting smaller. But then 3 months after that, I mean in June, because the chemo was started in January, so you can still see that the lesion slightly larger, but then what is more concerning is the appearance of the pleura, which is more undulated and you can see more thickened, which was not present on previous CT scan. And this was the CT scan at the time when the child almost succumbed, whereby you can see a more progressive area of the soft tissue or thickened pleura, very irregular, and that the hypodense area of the in the lung actually getting bigger. So just to show you, this is the first CT scan and this is the last CT scan. You can see a marked difference, especially in the reduction of the pleural effusion, but then the soft tissue and the pleura, it can really become more solid. And then you can see that this lesion actually getting bigger, and it indicating the progression of the disease. So just a few slides on the imaging modalities of parapneumonia effusion. Chest radiograph, I can't it is very important. I mean, it's actually a first line of investigation, but what I'm going to touch is on the lung ultrasound and CT thorax. Lung ultrasound is basically the gold standard for pleural effusion assessment. It can actually quantify the size and it can characterize what is the pleural effusion is all about. The sensitivity of the lung ultrasound on detecting or characterizing pleural effusion is much better compared to CT scan. And definitely we will use that ultrasound to guide us to drain the pleural fluid, as well as is be able to differentiate whether is it a pleural fluid only, or there is an underlying lung consolidation, or it's just a lung consolidation. And we can differentiate between pleural fluid versus solid, but we are unable to exclude between or differentiate between benign versus malignant pleural effusion. So these are the grading of the ultrasound in pleural effusion in a common infected pleural effusion. So in grade 1, you have an anechoic without any septation. You can see a bit more fibrin there at the surface of the pleura. In a grade 2, but we don't have much septation. But whenever you see some septation there, then we grade it as grade 3. This is when our pediatric surgery will intervene. And this is a more worse grade 4 pleural effusion with multiple septation and solid appearing components that it indicates that it's going to go towards the solid version of this pleural effusion. So this is how we do the ultrasound of the lung parenchyma. We assess all the lines and also the consolidation. So just to show you the value of the ultrasound, like these two patients, this is a two different patient, patient A and patient B. On patient A, which actually come with fever and cough, what we actually see opaque left hemithorax. And when we did ultrasound, you can see that there is an echoic effusion there. But a few days later, it becomes more fibrin and more complex looking. This patient actually had a empyema, and the child had a decortication because of patient also had a necrotizing pneumonia at the same time. And that's the intra finding. So this is another patient, again, a left hemithorax, opaque hemithorax, but on ultrasound, you can actually see that this is not a fluid at all. This is a solid lesion. So we know that we have to biopsy this patient, and we did a CT scan as well. It is actually a posterior mediastinal mass with calcification, and this patient actually had a thoracic neuroblastoma. So CT scan, on the other hand, is used for complicated pneumonia, the children with immunocompromised, and also to identify what's the cause of pneumonia. For example, recurrent pneumonia, especially whenever there is a foreign body or sequestration, or as preoperative assessment, and to exclude some congenital lung malformation. And CT does not have role in terms of characterizing pleural collection in children, especially. Okay. All right. So as the conclusion, chest X-ray is the first line of imaging, as is being illustrated in this case. Ultrasound is excellent in characterizing and quantifying the pleural effusion, and also will help us to plan for pleural effusion, aspiration, or drainage. And CT is helpful to see the extent of the parenchyma and pleural disease, as well as the mediastinum structure, and is indicated for a post-therapy oncology follow-up, as what we see in our patient. Post-infection treatment, imaging is not needed if the child is asymptomatic, but if the patient is symptomatic, then we should actually do the CT scan at least 6 to 8 weeks after treatment completion. So I think that's all. Prof. Hasniah, back to you.
Thanks, Prof. Faizah. So just actually a question, in this case, in this patient, we didn't see the septation even with 4 weeks of symptoms, right? That we normally expect in parapneumonic effusion. What about TB? Is there any clues in the initial investigation, like pleural thickening or calcifications in the CT? I'm asking whether is there any earlier clues that this is not the normal parapneumonic effusion that we've seen?
Okay, thank you, Prof. Yeah. So the thing is, in TB is a great mimicker, so it can actually mimics the bacterial parapneumonic effusion. The way the thickened and enhancing pleura is more or less the same like in bacterial parapneumonic effusion. So we can't exclude that, but as I pointed just now, that the way the progress of the pre-effusion, it does not give rise to a septation that in a time span that we expected for a bacterial parapneumonic effusion to have, then TB can be one of the differential, because it can be kind of subchronic kind of presentation. But of course, at that time also we need to think about other cause, non-bacterial cause, like malignant pre-effusion as well. But of course, the morphology wise, we can't differentiate between the two.
So we still need the pleural biopsy, I suppose. Right. I saw some questions from Prof. Jeff again about the histology. Right. Prof. Suria, do you want to comment on that?
I think Prof. Chia has asked about presence of foamy histiocytes, whether it indicates underlying tumors or not. It is not, because foamy histiocyte is a normal component of any fluid or cystic lesions. It did not point towards any underlying tumor. Unless the tumor has exfoliated its tumor cell into the fluid, and then we may detect it. But in this case, there's none.
Okay, thank you. So now we move on to our last speaker, Dr. Marfu'ah Nid Izamuddin. who is actually the clinical oncologist from CTM. She will give us an overview of the primary diagnosis of this patient and also and a review on primary adenocarcinoma in the pediatrics as well as the management and also the outcome of the patient.
Thank you, Prof. Hasniah. I'm not quite sure why my video is not working, but I think I'll just start, yeah, Prof. So I am generally going to talk about the disease itself. So we have heard about this interesting case where a 12-year-old is actually diagnosed with lung cancer. For us in adults, lung cancer is actually among the top 3 most common cancers, both in male and female. And it's actually the most common cause of cancer mortality. So that's the most common cause of death from cancer worldwide. So lung cancer in a child, I think we've heard a few comments from the previous speakers before that it's generally very rare, but we want to know whether is it just rare here or is it rare globally as well? What I would like to shed some light upon is there any differences in lung cancer in the adults population versus the pediatrics population? Would there be any differences in terms of how they present, or whether they spread differently or they present at different stages, the histological subtypes, and more importantly about the survival and prognosis. And then we'll have a look at an overview of lung cancer management. So if we look at the most common cancers in children, you can see lung cancer is none in the list. We commonly see all the hematological malignancy, but lung cancer, again, it is very, very rare. And when we want to talk about literature, there are only case reports, and it's very difficult for us then to understand the subset of disease and understand the outcome of it based on the rarity of the situation. So among the literature that I'm using for this particular presentation is 2 population-based studies from the SEER and NCDB database. So they are the biggest group of report in lung cancer, primary lung cancer in pediatrics population. So we know cancers in general is still very rare in pediatrics, and lung cancer is even rarer. Yeah, so it's only about 0.2% of all childhood malignancy. And this year database looks at about 10-year interval of lung cancer diagnosis in pediatrics, and over that period of 20 years, there's only about 310 cases of children getting primary lung cancer under the age of 19. And if in the adults, you will see about nearly 1 million lung cancer cases. And between the 2 genders, basically in a more male rather than female, but in the pediatrics population, those who had primary lung cancer seems to be of similar gender. And if you can see, there's a bimodal age distribution in the lung cancer cases in pediatrics, predominantly happening around the age of 15 to 19. So our patient is at the age of 12. So it is more of a disease of a teenager. When it comes to clinical presentation, as we see from the complexity of diagnosis of this patient, it does present with very non-specific symptoms. So we often see chest pain, we often see cough, but then more often we would think about other diseases in children. Other than that, they can also present with persistent fever or bronchial obstruction or unresolved infection. And this delays diagnosis. And most commonly, if we look back at all these cases of lung cancer in pediatrics, most often they are actually misdiagnosed with asthma or pneumonia. So in adults, we have the same problem as well, because they often present very late. And at times they actually present with symptoms of distant metastasis rather than symptoms from the primary tumor itself. So looking back at the database, about a third of pediatric patients with primary lung cancer will already present with stage 4 disease. So stage 4 includes spread to hematological, through hematological sites to other organs, but in this, and also the pleura. So in this case, the patient has pleural effusion, so that's already considered a metastatic disease. In adults, we see a lot more advanced stages at diagnosis, and as I mentioned before, commonly we see presentation with metastasis symptoms rather than the primary symptoms. In terms of histology, in adults, commonly we group them, the most common histology would be in the non-small cell lung cancer, which constitute mainly adenocarcinoma and squamous cell carcinoma. But if you look at the pathological spectrum in children, it's more diverse. And within this 300 patients within that 20 years of SEER database, predominantly they are actually carcinoid tumors, pulmonary blastoma, and mucoepidermoid that can actually behave differently. They have better survival, and to a certain extent, they are less malignant compared to the adenocarcinomas. Adenocarcinomas and squamous cell carcinomas, which are similar histology in adults, they are only constitute about 10 to 13% of the cases in pediatrics. But when we compare between the histology that is similar with adults, the disease pattern and the survival is more or less similar. So in terms of prognosis, this goes without age differences. Basically, when we look at cancer survival, mainly these are the factors affecting survival, which is the histology, the grade, the staging itself. So staging carries a lot of weight. When we know cancers in the early stages, the survival is a lot better. What's interesting that in this group of pediatrics patients with lung cancer, the role of surgery seems to be associated with better chance of survival. So when the patient has surgery as part of their management, their survival improve compared to those without having surgery. And this is actually highlighted in this particular table. In the row in the middle, the column in the middle is looking at median survival. So when a pediatrics patient have lung cancer with distant metastasis, their median survival is about 16 months, and 5-year overall survival is about 25%. So that's more or less the same when we have lung cancer in the adult setting. Okay, but you see the stark difference when surgery is part of the treatment. Okay, the survival improves almost more than double, about 79 to 80% compared to 30%. But then we have to remember, surgery is most of the time a modality that we use in the early stages, so not in the advanced stages. So by knowing a cancer early, then you can actually allow curative treatment for patient, and that translates into better survival. So looking at between the histological subtypes as well, you see the survival curve at the top are actually the carcinoids, the mucoepidermoid, and the actually pulmonary blastoma. And at the lower part is your adenocarcinoma. So it has a very poor prognosis. Median survival, as I mentioned, is within the 12 to about 16 months, about 14 months, and this patient had 11 months of survival. So now, going into an overview of lung cancer management, it's really driven by the histological diagnosis, okay? It's really important for us to know whether it's non-small cell or small cell, because small cells, they're more aggressive. They respond to different chemo regimes. We also need to know to decide treatment based on the stages, based on the oncological drivers as well. And this is something new in lung cancer and in cancer in general. So this is how we group histological subtypes in lung cancer. And what has happened over the last few decades is that now we're seeing lung cancer no longer as a single entity. So we also no longer just classify lung cancer based on their histological subtypes, but we look at their mutational status. So you can see what used to be a one entity disease now becomes a very complex heterogeneous disease, and different subtypes will respond differently to different treatment. And this is just to illustrate for maybe medical students and junior doctors who are not aware of cancer treatment. These are the treatment modalities that we use. The two top ones are surgery and radiotherapy are what we call local therapy, meaning it's mainly used in local disease. Their side effects and complications are mainly also very localized. And the lower part is your systemic disease. So this is what we use generally in patients with stage 4 disease. So the stage 4 disease, as you are aware, is already spread. It is within the bloodstream. So you need treatment that goes throughout the whole body. And chemotherapy, targeted therapy, immunotherapy are those treatments that goes throughout the body. Okay. And hopefully this is not too complicated. When you have early disease, stage 1 in the lung itself, then the treatment of choice would be surgery. When you get to stage 2, meaning it's now a bit more regionalized, okay? So you need surgery and then followed by some sort of therapy to control the disease further. So we can actually use chemotherapy, or in the last few years, we have started using targeted therapy as well. Okay, so stage 3 is even more advanced. Then you can't actually use a single modality treatment. You need a combination of treatment. So sometimes you might need to give chemo before you go for surgery. Sometimes you can't even operate. You need to use radiotherapy and chemotherapy and immunotherapy. Okay, so in the stage 4 setting, such as this patient, the main treatment of choice would be the systemic treatment. And how do we decide to use between chemotherapy, targeted therapy, or immunotherapy? It really depends on their mutational status. So for this boy, we actually send for EGFR testing. Okay, unfortunately, the EGFR mutation status for him is negative. So that's how we approach lung cancer, adenocarcinoma mainly. Yeah, in stage 4, we look at their mutation status. So we will send for gene testing, in particular EGFR, because that's the highest mutation that we see in our setting, and ALK, and then we have few rarer ones, ROS1, MET, and then we also send for PDL1 to look for suitability for immunotherapy treatment. And I would just like to highlight how different things are when a patient has EGFR mutation, although this patient has EGFR negative. If you look at the response rate with chemotherapy, generally we only get about 18 to 20% response. But then when we use EGFR targeted therapy, you get up to about 70 to 80% response rate. And looking at the disease control median PFS, yeah, if you use chemotherapy will only control the cancer for about 4 to 6 months, which is in this case of this patient. But when you use TKI, it's sort of like double the disease control with targeted therapy. Okay, so what about patients who have negative EGFR or negative ALK? So it is a very complicated table and algorithm. Unfortunately, this patient was diagnosed in 2018. So at that point, the standard of care was still platinum doublet. So the patient had cisplatin and gemcitabine. Nowadays, we incorporate immunotherapy in the treatment paradigm. So we look at patients' PDL1. Okay, if he has high PDL1, then actually the treatment of choice would be immunotherapy alone. But those patients with low PDL1, then platinum doublet plus immunotherapy for patients who are fit would be the standard of care. Okay, and this is to highlight things have really changed over the last few decades for us. And when we come to treating lung cancer in this particular group, okay, it is very, very difficult because one, we might not be aware that there is possibility of lung cancer in this population. And again, signs and symptoms were very non-specific. And a lot of times, because cancer is not a static disease, it progresses without treatment. Most of the patient will have distant metastasis at presentation, and that reduces survival. So in conclusion, I think we have to really put our thinking caps on when things are not very common or things are not responding to the way common diseases would actually respond to. The treatment for pediatric lung cancers nowadays are still extrapolated from adult studies, but basically the outcome and the response in adult and pediatric lung cancers are still similar regardless. So knowing cancer early allows curative resection. That's why early detection still saves lives. With that, I would thank you.
Okay, thank you very much, Dr. Marfu'ah, for our quite comprehensive review. So I do not see any further questions from the chat box. So I would like to actually to invite Prof. Hamidah, who is actually the consultant pediatric hemato-oncologist, as she's also actually directly involved with the management of this patient in the beginning. So to share her experience in managing this patient. Indeed, it's a very challenging case. Okay. Hamidah.
Thank you, Prof. Hasniah. I wouldn't say much because all the speakers and the panel of discussant has covered the case very comprehensive manner. I just would like to mention a few things which might be served as an additional take-home message alongside what Dr. Doris has mentioned just now, particularly for the students and the young doctors who might encounter challenging cases like this, particularly in the process of getting the final diagnosis. One, we usually consider the common illness and disease as what we mentioned by all the panel here today in the pediatric age group. So infection, TB, pneumonia, empyema. So these are the common illnesses and diseases in the pediatric age group rather than primary lung cancer. Two, however, when you do not see any response to your directed treatment, reconsider the diagnosis you made. Reevaluate the patient when you did not see that your patient responds to the treatment. When I read the chat box from Prof. Chia, one of the questions that he asked, what is the percentage of false positive TB results here, TB PCR? In the literature review, I don't see that any precise percentage of false positive, but bearing in mind that some of the factors that contribute to the false positives are contaminant of reagents and the aerosol productions. So this is where that, how that we improve in terms of getting the diagnosis of, TB would be very helpful to guide the clinician how that we move forward in treating the patient. And the third thing is that when you see a mass biopsy, so HPE is very, very important, and in most situations, it helps us, the clinician with, the final diagnosis of the patient. Although in some cases it could be tricky, but then, it is very important. And in such cases like this, molecular mutation, molecular screening is very important. The limitation that we had here is that we were not able to send, the whole array of molecular mutation. We only be able to send for the EGFR and also PD-L1 due to some limitation. And the next thing, number 4, is that, when we encounter challenging cases like this, collaboration between the adult pediatric pathologists and oncologists is very important to facilitate optimal diagnosis. This is why we are, having the MDT and also engaging, the adult oncologists, Mohd and Marfu'ah here to help us, with the treatment of the patient, because it is very scarce, extremely rare in pediatric age group, and the treatment protocol is being extrapolated from the adult protocol. And if we go to the literature review, there is no standard or no guideline, even consensus treatment for the pediatric lung carcinoma or adenocarcinoma. And the last but not least, consider sharing our experience with a wider, medical readers so that, we can help, the group or the scientists and the expert to improve understanding of the biology, pathology, and management of the patient in view of the scarcity of the cases. So I think that's all, Prof. Hasniah, because it
Alright.
has been extensively covered by the panels of discussant. Thank you
Okay.
very much.
Thank you very much. I think we have come to an end of this session. I would like to thank all the presenters and our panelists today for their contribution, as well as the audience for listening. Thank you very much. For the medical students, please stay back for the quiz. Thank you. Okay, Doris, you may start the quiz.
The quiz is by the faculty people.
Okay, all right.